Thank you so much, Susan. I'm really honored here. And I'm kind of anxious to here, just finishing up here. Obviously, there is so much great energy here and passion and commitment. And I don't know how to call it dedication, some sort of really great energy coming out here of this whole 2 day conference, And I was just talking with Judy about how much it's going to be important, guys, to, after you leave here today, is to get mobilized more, to really advocate more, to really, create more of a movement, of a more grassroots movement, where you're really working. And I would call it more like a revolution. It just really, this is how change happens. It's going to be you who going to be driving the change. And I'll tell you from my own experience with that. But first, I want to very, very much thank, Judy and Brittany and Seal, Department of Health, everybody for this really amazing work they've done here and getting us all together and really learning from each other. And hopefully, as I mentioned, you're going to be able to leave here really energized, with more passion, and really more commitment and dedication, to the work you're doing. I want to try to avoid overloading you with information here. I don't want you to leave here feeling that, oh, here we go now, another lecture and too much of, there's too much to learn here, too much to really absorb. I want to avoid that as much as I can. And I'll tell you, usually when I'm approached about a talk about motivation interviewing, I've been more and more reluctant to say that, I need an hour because it's really so hard to capture, the essence of it in an hour. And we're talking about the work, the 25-year work that has evolved into what we know about the approach. But this is really a perfect fit. It's a natural fit with what the kind of work we're really doing here. And how many of you are familiar with motivation interviewing? Oh, wow, that's amazing. And familiar and practicing, supervising, training? Wow, all right, yeah. I know, but the thing is that a lot of people do it sometimes without realizing they're doing it. And because fundamentally what it is about, and as I recall from a lot of my mentors, it's about what matters, at the end of that relationship and connections. I mean, this is what we're really talking about. Obviously, relationships and connections would not happen if we're going to be judgmental, if we're going to have a lot of mind, filled with prejudices, and really misperceptions and really preconceived notions about things, about people. And I'll tell you just briefly before I get into the topic itself, just to give you a little bit of a context of how, that I'm standing here now, how I ended up really here. I've been practicing addiction and HIV psychiatrist for close to 25 years now. When I started my training back in Syracuse, New York, at that time, I knew nothing about substance use disorders. I knew nothing about HIV, in terms of really the clinical work. And I had amazing mentors at that time that were assigned to me at the VA, and really it was like a more, okay, well, I'm gonna go and see my mentor, one of them. Basically, I had one for the HIV and one for, because I was supposed to do the clinic there, and then one for the addiction at the VA. And at that time, as I said, I had no really knowledge. I had no interest. I don't know if I had any interest in working with that population. And fascinatingly enough, I'll tell you from that moment, when I met with my mentors, there was some sort of an instant, really chemistry that happened, when they told me, when they approached me and said, they suggested, why don't you go and really, work on the inpatient unit, the addiction inpatient unit, and would you be interested in joining us at the HIV clinic? And I said, sure, of course, and I had no idea at that time what to really expect, and so I went with really very much of a clear mind, and honestly, it was like an instant chemistry. It was like an amazing feeling I had that, this is exactly, the populations that I want to work with. Whether on the, addiction, part or the HIV clinic. The HIV clinic in Syracuse was a part of the ID clinic. We didn't have any separate clinic then. And you talk about the early 90s. Early 90s also, treatments for HIV were very, how can I say, rudimentary. They were not really very advanced, but also nobody was in the ID clinic. Nobody was really addressing even the substance use or depression or anxiety in populations, who are HIV positive. So really that instant chemistry, in a sense, mobilized me towards really the clinical work, obviously, at that time, but also to build a career, to build an identity that I consider as an HIV and an addiction psychiatrist. And big part of that was also what drove me more to that field. Was at the center of it is the tobacco use disorder. So from really very early on, I was really very much passionate about that work. I wanting to make the change and making a difference, not on just really on a level of working, with practitioners, but we're talking about systems of care. Because I do strongly believe systems of care will change if you, as practitioners, would really mobilize that system of care. And again, I want to go back to the importance of how much the work that you do can really change systems of care, can change people, and how you can influence people, in the work that you do, can really become transgenerational. I mean, this is what we need to do, the sustainability. We can't sustain the work we're doing here unless we keep going and we keep doing and we keep really, transgenerationally, disseminating, what we do. And really, obviously, you won't be able to do it very well unless you really believe in it. So big part of it is really you have to do it from the heart. And I know, guys, all of you are here because what you're doing is from the heart. And you want to really make sure that also you're going to continue with that mission to really change, that a lot of the next generations, and to really kind of mobilize, the whole process of really, we've talked about obviously the context of substance, of the tobacco use, sort of talking about the context of the LGBTQA, health, we're talking about really, working with people and looking at the work that you do as more, not just really from a scientific or clinical perspective, but more from the humanistic perspective. And this is what I've really learned throughout the years of my career is that I can be a great scientist, I can be a great researcher, be a clinician at heart, but all the work that I want to do has to be coming from the heart. And if it is not coming from the heart, that's not going to make any difference. All right, so now we'll talk about the motivation interviewing. And this was basically in 91 when I started my residency training. That was the catalyst, that initially got me to be interested in the field of addiction and HIV. And it was back in 91 when I was given that book, the first edition of the Motivation Interviewing. And fascinatingly enough, at that time, I had no idea what it was, that approach. And it was really, mostly, it was used in addictions at that time. There were no studies looking at motivation interviewing in other, healthcare, fields. Like now, as you know, there's a huge explosion, of research and really clinical applications of motivation interviewing in different, any sort of really settings where there's a behavior change, and also different settings, other settings where there is also more than really behavior change. So really that kind of, in a sense, when I read in the first edition, that was really fascinating is that, in the preface of the first edition, I read that a word of informed consent by Bill Miller saying that this approach is likely to change you. So I kept reading here, what is that? What does that really mean, And in fact, I knew now what it means back then. At that time, it was a therapeutic approach, that was just got started, and people were really obviously talking about it more and more. In fact, you look back at Bill Miller, one of the pioneers of motivation interviewing, he talked about the approach back in the 80s, but there were no research behind it. It was more like a clinical observations. So when I'm talking about what likely to change you is the approach is more the fact how we engage people, how we deal with encounters with people, not just really with patient encounters. I'm talking about people in general, how we establish relationships with people, how we really, do any sort of work. with patients, with their families. So again, what has really changed me here is more how I relate to people, how I listen to people, how I engage people, how I'm present with people. That was not necessarily something that they teach you, necessarily in medical schools or residency training, or, there is always, this kind of a sense of they want to overload you with the scientific piece, without really, incorporating or integrating the humanistic piece of it. I want to try, as I said, don't want to overload you here. I want to give more opportunities for you to really share your thoughts and experiences here. But just very quick principles about, that are very important to understand when it comes to really relationships and engagement. For example, the self-perception theory. First, self-perception theory has been around, since the 70s. And what it really means is basically the more somebody verbalizes a position, whether it's either positive or negative, want to change or not change, the more they will commit to it. The more I will commit to whatever position I really decide to take. All right. So the second principle is really very, very crucial when it comes to encounters with people, is the reactance theory. Also, this has been around for a long time, also the reactance. These are the early basic psychological theories. The natural human tendency to reassert one's freedom when it appears to be threatened, even if it hurts them. I mean, think about it here. We have the tendency to always want to tell people, oh, if you smoke, it's going to kill you, if the scare tactics and everything. Well, something, first of all, the tendency for people going to really reassert themselves, whichever really they want to do. I mean, unfortunately, we've had that tendency to really not be fully respectful of people's autonomy. And when we are not, we'll lose the people. We'll lose it. We will lose any sort of a potential influence we can have on people. And also in the language, and we've been talking about language, I believe for 2 days here, and the importance of the language, and the impact of language, and the therapeutic impact of language. Two things I want to mention about key concepts, when it comes to language in general, not just the motivation interviewing, is the change talk and the sustained talk. The change talk is any sort of a talk that you hear from people, we call it preparatory talk, that indicates a movement toward a particular change goal. The sustained talk is more the status quo, is people when they really refer to wanting not to change. Doesn't mean it makes it really bad. Obviously, it tells you where the person is. So how do really people change? When we think about it in a simple way, obviously, when I make some change talk, and make statements that I want to change, it doesn't necessarily translate that I'm going to change. You can say, I need to quit smoking, I have to quit smoking, these are my reasons, but doesn't mean that it's going to be moving towards doesn't mean that this person is going to move towards action. What moves people towards action is what we call the commitment language. When we hear people, using a lot of that language of, I'm going to do it, and this is how I'm going to do it, and it goes with what we call the activation. There's an activation language, and people start taking steps. And this is how it leads basically to the change. So if you think about it, what we want to hear more from people, change talk that's going to be strengthened, leading to a commitment language. So if they have more commitment language, they're going to be more likely to do it. So this is what's predictive of change. And this has been really studied over now for at least 12, 13 years. We have a ton of studies that have looked at the psycholinguistics that are really fundamental to any sort of a therapeutic encounter, not just motivation interviewing. And as you know, I haven't even talked about what motivation interviewing is. So you see, just here gives you some kind of a sense of when you hear people talking about what does that mean, commitment language, that goes from the weakest to the strongest. You're going to hear a lot of people saying, well, I'm devoted to do that. I agree to do that. Well, I think I might do that. I think I might change. I shall change. I give my word. So it makes a difference. What you hear makes a difference. But you know something? The problem is we don't always listen actively to respond to what we hear. We sometimes want to just hear, whatever we believe we should hear. And we lose that ability to actively listen. And, I believe most of our problems, here in the U.S., are from people not listening to each other. Look at the government, and government official, anywhere, we do not have the ability, or we refuse to listen. Because if you listen, you have always the ability to negotiate and to work through issues. This is really all across, in not in corporations, in healthcare settings, in any sort of really settings. So when it comes to really basically the rapport building and the engagement, it's always important. I'll tell you, this happens a lot with me, is that we have patients that I see the first minute, I feel that instant chemistry. I feel that immediate engagement. I have people that I struggle more to engage, but doesn't mean, that I cannot still do more to really engage them. And one thing that we need to think about is to individualize and personalize, any encounter. And again, we don't want to talk about really, populations. We're talking about really human beings, individuals, and otherwise we're going to make assumptions and we're going to cluster everybody in the same really category. And this is really extremely important because, that's going to dictate how they perceive us if we're going to really approach them as big cluster of people or populations versus individual people with their individual needs, and really, also special, needs in a way. And this is very important. I look at it from really what we really need more like a system that, I know we use a lot of the word cultural really competence, cultural, all this, we always incorporate that word. But I think most importantly, what we're talking about, every person has a very fascinating, cultural background, and we're talking about more from really not from a narrow-minded perspective. We're talking about a larger perspective in terms of the cultural, abilities, and really context. And I'll talk about how it really fits in, into the conversation here. But I think if we do not really, listen to people and really pay attention to their cultural context and who they are, I know that everybody talked about it, Amy talked about it, and, then we will not be able to influence or make any sort of difference. There would be like a typical encounter that goes really insignificant, and they will perceive you as just more of another professional. The other thing is that, that is very hard for us to really adopt, which I know we talk about all the time, is that collaboration and partnership. When you are working together, you're going to be more productive. You're going to brainstorm better. You're going to come up with better ways, to deal with issues, with conflicts. And thinking of it from the point of you might be the expert in that encounter, from a professional point of view, the field itself, but you are never going to be the expert on the person. And something, obviously, when together you are with that person, then you can really bring your own expertise into the field, to the encounter, and they will bring, their own expertise on themselves, and they will really give you more of what you really need to proceed with. And, and the biggest thing is that, that what is really important this way, then you do not feel like it's up to you to do it. You have to respect where they are, and you can influence the process, but it is not you. It is not about you. It is never about us. It's always about the person who's in that encounter that's gonna really, be mobilized there. The other thing that is very important is that, and we hear that all the time, well, I don't have time to listen, I'm seeing so many people, and I'm very busy, I have so many meetings and everything. Well, there is a paradox, in healthcare field, is just slow is fast and fast is slow, and give the example there, when you act like you have 30 minutes with a patient, it will take all day. And if you act like you will have the whole day with the patient, it will take 30 minutes. You know what I'm talking about here. So what is really the issue that we have a hard time, or we always find these excuses or reasons not to listen to each other? And trust me, it makes it so much easier if we listen actively. I'm talking about listening actively. What I mean by that is more listening with the accurate empathy, with being present with the person, transposing yourself into the person's world, and it doesn't take much time. It is not the time that is the issue. It's your really basically commitment to wanting to do it and your belief in the importance of doing it. And if it is not there, so, then it's not the issue to use, the time as the issue. You can still accomplish a lot in a short period of time if you do it the right way by really listening. Again, we have that sort of really belief in healthcare field. We know it very well that we need hours and hours with people to really move them, and mobilize them and motivate them. That is not really true. As you know, also, we talk about really ambivalence, as very much of a natural process that people always struggle with. People are always struggling with wanting to make a change. There's a part of them that wants to do it for different reasons, the other part that doesn't want to do it. And what is very important here to normalize that ambivalence for people instead of really pathologizing it. We have that tendency. We want to always really, shift the balance towards what we believe is the good thing for them to do. Well, something, again, that goes back to the point, who are you to tell me what is good for me? You can sit and give me all the reasons why that I shouldn't be really smoking, but, I want to continue smoking. That's not the reason, because you told me so, and you gave me all these reasons that I'm going to follow what you're really telling me. But patients respond to that better if they have a relationship with you, obviously, and if they know that what you're saying and what you're doing in terms of the advice is given in an empathic and collaborative way. They respond. Patients would respond. But unfortunately, we have that tendency. We want to always move people in the direction we want them to move. And then this way they tell you, yeah, I'm going to go and really change. I'm going to quit smoking. And they walk out and they go back to the same behaviors. The thing is, I gave the typical example there about really the two things to watch. We talked about the self-reactance theory, but I want to talk about also the righting reflex that we see in healthcare field is that this whole desire to fix. We go into this encounter with people, with the patients, and then we want to fix the problem, or we want to come up with the solutions and tell them, okay, well, listen, this is what the problem is, this is what you're going to need to do, and if you do this, and this is what's going to be the outcome. This does not work. Even though with a good intention, when you go with wanting to fix, it will backfire. No, the patients also do not expect you to fix. It's your problem as a practitioner, our problem as a practitioner, that we want to fix. So again, that does not come from the patients. The patients might look for some guidance. They want you to really kind of help them work through the process. But if you're going to go and really try to impose and try to really, even give that sort of an impression that you want to fix, that will really be backfire. The other thing is that always really remember when it comes to the ambivalence, I want to look for the glass half full, not half empty. So instead of always trying to really ask why people don't change, how about if we ask why people change? We always have that tendency that we want to always find the reasons why they don't want to quit, why they don't want to do this. Well, how about finding, some reasons, why they want it to change? They might not be very strong reasons, but there are reasons that you can start working with. But unfortunately, our tendency is building on the negative, and again, I'm also one of these practitioners what we've had that tendency to really do it. Obviously, over the course of the years, I've learned more and more to correct myself and to learn from my own mistakes, and it's a continuous process. It never stops, and that process I learned from the patients. I mean, they are the best, to really help me really change my bad habits, and based on the responses that I get from them. So again, always remember that, to focus on the positive. And this whole thing about, unfortunately, always remembering that when you're really going with to discuss the situation is to allow the patients to describe their struggles. Because sometimes we don't want to also listen to what they are struggling because we want them to change right away. And what we end up doing is that we end up wanting to push them in that direction. And if you're pushing them at the time when they are still very ambivalent, it's not going to work. And they might tell you, yeah, I'm going to take my medications. I'm going to follow through with treatment. I'm going to quit smoking. I'm not going to drink as much, And I might say this to you, but what they're going to be doing later on is not going to be following through with that. You know, this is what I mentioned. This is really some of the impact of the writing reflex. Think about it. The desire to fix. It leads basically to people feeling invalidated. They resist, they argue, they discount. You know, and I was really mentioning early on is that unfortunately in the healthcare field, we have a tendency when we go in an encounter with a patient is that we want to try to win an argument. You know, there is this tendency that, okay, well, it's gonna be my argument against yours. Well, trust me, you go with that attitude, you will always lose. You will always lose that sort of really if you're gonna go with a wanting to win a particular argument about something. And again, the problem is that if they're gonna feel this way, if they're gonna feel like they are not really heard, they are not really validated, they'll never come back. You want them to come back. You want to make sure you're going to continue, with that, process. And, as I mentioned earlier, what really matters is the relationship. The relationship cannot be built if we're going to be invalidating people and then we're going to be pushing them, and pushing our own agenda on them. Now, so this is the context, right? All these principles, all this. So what is really motivation interviewing? When you think about it, two things. I don't know how many of you are familiar with the Rogerian, client-centered approach, and I see somebody shaking your head there, and which is basically the person-centered approach that is based on the accurate empathy, the unconditional positive regard. These were originally, that was the foundation. But with the person-centered approach was more like a non-directive, more like people would share, but there was no specific goal. What MI is also totally the opposite of the confrontational approach, the confrontational style. They used to call it in the field of the addiction the attack therapy. Attack therapy used to happen, back, 25 years ago, 30 years ago, and something, it still happens in some treatment settings, some addiction treatment settings, and again, the MI is totally the opposite, that of, the confrontational approach. So again, I don't want to overwhelm you with too many details, but fundamentally what MI is, and I know I give 3 definitions here, so one definition for the layperson, one definition for the practitioner, and one as a technical definition. Fundamentally, it's a conversation about change. Let's simplify it. It's a conversation. It's a therapeutic conversation. And I know sometimes it is very hard for us to always go into an encounter, with a patient and we want to do something. Instead, we want to converse. We want to really engage to have a conversation. And I know it might not be, obviously, it is not, easy, but it's kind of, as a principle, it's very simple. And what it's based on is that sort of a collaboration, working together, partnership, and it is focused. It's strategically focused on what you really want to accomplish in the session. And most importantly, it focuses a lot throughout this whole process of the engagement, on the language that is really used. And particularly what we're talking about is the language of change. Remember we talked about change talk, commitment language versus status quo. So what do I want to do here? I want to work with patients to mobilize them towards change. And how is that going to happen? Strengthening their motivation for change, strengthening change talk, eliciting commitment language with the hope that this is going to be leading to change. I mean, as simple as it is. But always remembering that people would not change unless they also resolve their ambivalence. If they are still highly ambivalent, this is what you would want to work on. And 99% of people who present to us, in any sort of a setting are really very much ambivalent about wanting to make the change. So we would want to really address it, as a part of really the engagement process. So we talk about really all these things, so what defines MI as the relational piece, that's what I'm talking about, is that spirit. I use the word spirit. And again, it kind of really reflects what I've earlier mentioned, is the collaboration, working together, the partnership, not working on the patient. The evocation is huge. It's at the core of what MI is. And what I mean by that is when you bring things from within all the way out. In order to evoke from people, you want to be present with them. You want to be listening actively. Otherwise, how are you going to come up with any question that's going to be evocative in nature? But that is the curiosity about the fact that I want to know more. This is what really Steve Rolnick calls it having a curious and itchy mind. You go into the encounter and you unclutter your mind, and you are present and you are curious and you look for more to evoke from patients. And they will give you all what you really need. And they'll give themselves what they really need. So the most importantly, as I said, at the core of it is respecting autonomy. Nothing can be accomplished if we do not respect people for who they are, and respecting their decision making. Even though sometimes we do not like it, or it's against really health, promotion, approach or philosophy. And this is what I mean by the acceptance and compassion. Acceptance is what? If we do not believe to accept people for who they are, that is, you're going to lose the person. There is no way. If they're going to sense from you that you are not accepting of who they are. And this is different from, we're not talking about accepting their behaviors. I'm talking about accepting who they are. And obviously this is going to be very much tied to this compassion. And this is totally against what I mentioned, the confrontation or education and the authority. I am here, being here and they are there, and I'll tell you what to do and this is how you're going to do it. And unfortunately, it's still very much of a common practice in medicine, in healthcare settings. So with that spirit, there are processes. And I know I don't want to, again, confuse you too much, but the processes guide really the whole conversation you're going to have. And with the processes, obviously, if you don't engage first and you don't focus the conversation, it's not going to happen. And you evoke more to really address the ambivalence. And eventually you start planning. When people have really resolved their ambivalence, they want to start planning how they're going to move with the change. So these are the processes. You have the spirit, which is the presence with people. And then how to do it. What is the technical piece? Technical piece is 4 basically skills. Simple skills in a way, but obviously very difficult to really, implement consistently. The open questions, affirmation, the reflective listening, which is at the core, it's the heart of really the MI in a way, and it's a learnable, we need to remember that the learnable skills of the reflective listening is the accurate empathy. When I'm referring to accurate empathy, what the client-centered approach. And the summarization or summary. So when we talk about the affirmations, guys, there is this tendency that we want to encourage people for the work that they've done and everything, and unfortunately it ends up really coming across as cheerleading. Good job, fantastic, so all these all that sort of, that's, it's cheerleading. Cheerleading does not point out the accomplishments, of people, and does not point out really, because it's about you. When you say you're doing a good job, instead of really saying, look, you made a lot of the effort to really get here to your appointment. There's a big difference. You're really affirming the work they've done, not how you feel about the work they've done. Obviously, if you affirm the work they've done, obviously you feel good about what they've done. And again, this whole idea of a scare tactic or making people feel bad enough that they will change, there is still that kind of an approach, unfortunately. And, and unfortunately, the problem is that a lot of people believe it works. A lot of people believe that, that if I really scare them, or if I really, because you care. Obviously, you scare them because you really care about them. It's not that you have a bad intention, but it comes across as really, even if you have a good intention, it doesn't come across as really therapeutic. As I mentioned, the reflective listening here, what I want to really talk about, and this is really fundamental to learning MI, is really, it's more of a testing hypothesis. This is not an interpretation. And when people listen to themselves, they are more likely to follow through what they are saying to themselves. So which means, reflective listening, when you reflect back, whether you're reflecting the meanings or the emotions, that can really generate more from the patient, and it can invite them to share more and more, unlike asking questions. And the most important thing, obviously, when you're reflecting, you're clearly reflecting without any sort of judgment, without any sort of really criticism, without confronting, which sometimes it is very hard for people to do. And also you need to know what your point is by reflecting. Where are you going? So there are two types of things that we do usually with the reflections. We want to either mobilize people to start thinking about change, or we want to stabilize the process. Because, they can come in, oh, I don't want to quit smoking. So you want to keep the conversation, you want to keep the conversation going, and the only way to do it is to reflect, and keep them engaged and invite them to talk, even though they are not going to share with you much of the change talk. But you can still fish for that, by really engaging them and doing a lot of the reflective listening. The giving advice, we do it all the time. The issue is not really giving advice is really very important, because a lot of patients ask for it sometimes. The issue is that we want to always emphasize that you're giving the advice based on what you know, or if you know the patient very well, the context of what they are going through, but you don't want to end up really imposing an advice. And this happens a lot. And you want to always preface, look, you ask me, my opinion, I really appreciate it. I'm going to share with you what some people do, and based on what you've struggling with, what could be potentially helpful. We can go through 2-3 things, and it's up to you to choose. You might tell me, look, these advices I'm giving you might not really work for you. Then we can really brainstorm other ones. So there has to be that sort of a spirit that what you're doing is, and this is the process, what we call elicit, provide, elicit, is that we want to hear from them. You can provide that, and you elicit back. You don't want to keep the conversation one way. You want to engage in what we call like an exchange. You exchange back and forth. And this is really the best way to do it. And always remembering when you're giving an advice, if you were to give advice, to always ask permission. If you want to make any sort of really statement about something, an observation, or whatever you would like, please always ask them permission to really follow with that. Talking about really respecting autonomy. One principle that is very important, that to understand in the world of motivation, not into motivation interviewing, but it's also in any kind of a therapeutic, encounters. I don't know how many of you are familiar with the equipoise principle. Some people, Amy, and okay. I'm going to explain what it is. The definition of it is counseling with neutrality. It's hard for us to really counsel somebody in a way with neutrality. We want to always inject our own things. And it is not by itself a therapist attribute, So we're talking about really, it's a conscious clinical decision to try not to influence a person's direction of choice or change. We're going to tell me, wait a second, but here we're having conversations, so we want to mobilize people. Well, yes, we would want to mobilize people. Obviously, they know that we are promoting health. At the same time, if you're going to go with that conscious decision to influence them, in one direction or another, that is not going to work. And this is really exactly what our aspiration as practitioners, is that I asked the question here, should I proceed strategically to favor the resolution of a person's ambivalence in a particular direction? We want to address the, or do I want to maintain that neutrality and not intentionally or inadvertently steer the person in one particular direction? Well, MI was really designed initially for basically the first one, the former, situation. But also at the same time, when it comes to a conscious choice and you identify a change goal, like for example, I gave the example of a couple who presents, and he or she want to really, the person, they want to really have a kid, and they disagree about having a kid, and you want to be extremely careful how you conduct, the session there. Because you are not going to be, in a way, influencing, the people there, the couple in any sort of a direction. You want the couple to figure out how they could really, so you want to facilitate that process. And obviously, when it comes to really aspiration, we want to move them in terms of resolving their ambivalence, at the same time, any way whether you choose an aspiration or the equipoise, they are really very much tied together too. They are both choices, they involve equanimity, collaboration, and autonomy. So it does not take away any sort of the principle that we've talked about. So always remember, you influence people, you do not really give them any kind of a sense that you want them to move in the direction you want them to. And something? This is extremely challenging. Very hard, because again, we want to move them in the direction of change. We want them to really, resolve their ambivalence about any particular issue. Well, unfortunately, if we're going to inject our own and then not let them figure it out, and you know something, the reason why? Because I believe in their ability to do it. If I don't believe in the ability of the person to really change, then what am I doing there? It is not about me. And this is exactly the opposite of what I mentioned before about the impact of the listening, evoking an empathic style. As you know, when people are affirmed, they are really more, they are less defensive, they are more open, more engaged, they come back, and you can continue to work. So I don't know how many of people are really skeptical, and we see that a lot, that, okay, well, what am I talking about just an approach that is really come out, obviously, with no scientific evidence or no support. The support, the scientific evidence, the empirical evidence is huge. And something, I don't want to really go necessarily and talk about how many studies necessarily we've done with that, but there is an explosion. But something, why MI has been really adopted more and more, because it's the natural way of being present with people. And regardless what this is about, in terms of any sort of encounter or any sort of really in really different administrative settings, in different really, now that's, for example, MI has been used more and more in some corporate, business company where they won't want their, employees to be more productive, to be more respected, to really be collaborative, so there is a lot of that. So just gives you some sense of really how we've evolved with the studies. Look where we were in the 80s, and look where we are now, in a sense, with ton of studies that are really all across, any healthcare settings. So what is my argument here, if we're gonna talk about really, the why and how, in a sense of MI for the LGBTQA, so first of all, I know that I don't wanna repeat, what's been talked about already here. That if you look at really basically the studies, and the numbers, for example, this is the cigarette use among sexual minority versus, sexual majority, as huge rates of tobacco use disorders. Huge, really even more when it comes to substance use disorders. We have much, much higher numbers, of really sexual minority people, adults, that use compared to sexual majority. And we're talking about all across illicit drugs. Not just really illicit drugs as well as alcohol. And again, the biggest challenge here, when we talk about substance use in the context of it, we're talking about also people identified as having, substance use issues. They don't get into treatment. There is no access to treatment. There is a very small percentage of sexual minority people, also sexual majority people who engage, who have access to treatment. So again, what we're really doing is that if we don't get people into treatment, obviously the negative consequences are very much significant, on all levels. And again, we have a very major problem. We see it now, for example, with the opioid epidemic. So the question, I know there's a lot here on the slide, but one point I want to make here is, is that MI is really perfect fit, as I mentioned earlier, but we're talking about a perfect fit about being present with, people. And I don't see it very much really different here when it comes to also, it kind of defines more, as we've talked about already, the discrimination, the stigmatization, the prejudice and all this. But remember, I don't know if there was any discussion about what we call the introjection phenomenon. Did anybody discuss that? No. Let me explain a little bit what that is. When people from a certain culture start really internalizing extrinsic motivators. So which means, I would go around and pretend, because of my culture, my family background, I go and pretend, that I'm not gay, that I'm, or I'm not trans, or any sort of thing, And what ends up happening, this is what the introjection is. In fact, what ends up happening, people start really living, in a sense, painful life, fake life. They are not living the life they wanted to live. And what ends up really happening, you're going to see more people, engaging in suicidal behaviors. So people living the life that have been imposed by whatever cultural context they live in. This is introjection, and you see that a lot. I've seen it a lot with patients, who are HIV positive, they go out, and they don't want to disclose, their status because they are so ashamed and embarrassed. They don't disclose it to their family members. They don't disclose it, people, they are involved with. It becomes very much really a huge problem, because what ends up happening, they're going to be acting, based on the fact that they have never accepted, in a way, come to terms with who they are, and they introjected other people's perception of who they want to see them. And MI is really perfect here, because remember what I said about the acceptance of people for who they are? When you're conveying that in an encounter, people disclose more and start being in touch more with who they are. So we talk about really, we're addressing particular goal or a behavior, whether smoking or something. But obviously, you cannot do any of that work if you do not believe in really accepting the person who is really with you, having that encounter. And this is extremely important in that context. And we have also a ton of evidence-based practice and efficacy. I can tell you in tobacco, substance use, HIV risk behaviors, that we've talked about, people are struggling, all across, But again, in that kind of a context, is that it's a science-based, as I mentioned, and a humanistic care to clearly, historically marginalized population that continues to be marginalized. This is what I wanted to mention that defines exactly what I was talking about, the cross-cultural encounter, and this is where, the MI really fits in totally. We talk about at the top of that triangle is the acceptance. And then how it's really displayed is the curiosity, that you want to get to know the person. And how it is done? The accurate empathy. And this is how, when you're really engaging that conversation, and trust me, when you do it, and I know you've experienced it yourself, is that people start really opening up more, and you can do a lot of the work with them, and they can come up with a lot of also resources. If you believe in their ability to come up with the resources, they'll give you the answers to what their struggles are. All you want to do is facilitate that whole process. This is one I want to mention, a couple of slides here, and we'll finish up here. In the field of addiction, and I talked about confrontation, versus MI. These are early studies that have been done, and we have a solid data on that, is how you deliver a treatment matters. And when we're talking about MI, as you can see here, the difference, when there's more change talk, when it's delivered, when there is more an MI approach versus confrontational approach, and you have more what we call now the resistance, or we call it like a discord, like, people, in a sense, not moving in the change process if you use a confrontational approach. As simple as these are studies that we've done a long time ago. And unfortunately, there is this kind of a still, and that doesn't just apply to really substance use disorders or addictions, it applies all across, healthcare settings. The other thing that I want to mention to you about this fascinating study back from the 70s, the HARP study, the high alcohol and recovery potential. What this study looked at is basically that was done in 3 settings, and it's in the context of alcohol use disorders, and counselors were really told, look, we're going to have you work with a particular group of patients that are highly motivated. We found out that they are highly motivated because we did psychological testing on them. We evaluated them. They wanted to change. They wanted to quit drinking. They wanted to go back and have a more productive lives, and okay, so the counselors went and then worked with these patients. And fascinatingly enough, these patients, in fact, did better. When we're talking about did better, they were more motivated for counseling. They were basically showing up for treatment. They were not drinking as much. And in fact, not just within, the 6 months, also within 12 months. So the question is, well, how did that really happen? We kind of wonder about that. Well, let me tell you something here. These patients that were really selected were randomly selected. There were no psychological testing. Nobody knew whether they were motivated or not. And you know what happened? It's the counselor's expectations and attitudes that made the difference. This is what matters. If I'm going to go with a patient and not believe that they are capable of change on some level, they won't change. At the same time, if they are not willing to do it, that's up to them too. You would have to respect that piece too. But you cannot go with really not thinking that you want to always give somebody the benefit of the doubt, in a sense, and really believe in their ability to change. And if you go with that attitude and with that expectation, trust me, you'll see miracles happen. And and again, expectations can be also self-fulfilling prophecies. And this is really very much important to always keep in mind. So my wrapping up here a little bit. So why do we need to train an MI all across? As you know, I gave you already all the reasons to do it. And again, one thing I want to mention, that the professional role does not appear to affect its efficacy. So which means, anybody can learn motivation interviewing. Anybody can use it. Anybody can practice it. Obviously you would want to learn. You want to get the supervision. You want to get the training. But there is no such thing as because I'm an MD or he's a PhD or whatever, they can do better job. No, there's no evidence for it. So this is something that universally, to any levels, even we can train, our unit clerks, to do really have motivation interviewing skills, and they can really be more engaging. We'll talk about, your clinic, and how you change, the approach, and the attitudes and everything. Anybody can learn, these skills. I think this is where our problem is. And when we talk about empathic skills, it's a learnable skill. People can learn to become more empathic, more compassionate, and more understanding. But you're going to have to equip them with the right ways to really do it. So you cannot expect people to really, become very empathic or, compassionate without really some skills that they would need to really learn and need to practice and then need to be really, supervised for. And again, always remembering, it is not necessarily hours and hours, a lot of adaptation of motivation interviewing can be quick conversations, brief interventions, 5-10 minutes. In the tobacco area, basically 5-7 minutes are really tremendously helpful, and they mobilize people so easily and quickly. So again, we need to keep that in mind, and how brief interventions really work. Basically, they work through, activating what we call self-regulatory processes. People start thinking more when you really start engage them in any sort of a conversation about any behavior change. So one thing I would like you to really think about here, before we finish up, is what we call the two types of really practices that we engage in. We can engage either in practice or deliberate practice. The mindful practice is the deliberate practice. We can practice anything and do anything. We can go and really chat and talk with patients or, anything we're doing, but there's a big difference if we're really practicing in a deliberate way. When you're practicing in a deliberate way, you're really putting too much effort into it. You're focused. You're mindful of what you're saying, what you're doing, how you're doing it, and it takes, obviously, more work, and it's more challenging, requires more practice, in terms of learning how to do it. But in terms of really practicing, not in a deliberate way, you just go and repeat whatever skills you've learned, and you can do it in a robotic way. And you know something? That's not going to have much of any impact anyway. Okay, great question. So the question is about with children and adolescents. The middle school, starting with middle school, obviously we have a ton of studies with adolescents, well established, from the age of, obviously 14, 15, till the like young adults. But with the kids, it's kind of challenging because you talk about an 10-year-old, 11-year-old, and it's very challenging because cognitively they can't think, to a point where they can identify, what sort of really change. You want to adapt it more. We don't have enough, basically, studies. We are trying to now implement, and there are a ton of studies coming out, working with family members to motivate the kids, particularly in the context of asthma, chronic medical illnesses, or any sort of that. So it is really more challenging at that age, but more and more the studies we've been doing now is when, 13, 14, kids with age of 13, 14, they are capable of really responding. And particularly we do it, particularly in the substance use, but also in any management of any chronic medical illnesses. Because kids at that age, they could still manage their illnesses. They can make changes. The thing is that you want to be careful, with where cognitively they are, and tailor it to where they are, but it can really make a difference. Obviously, the approach is, you have to approach, use the MI approach or the MI style. I think it's when you're really exploring any particular change, any goal that you want to change, you want to really kind of adapt it, to the whole really age, and developmental, the developmental level. There is a great book that came out basically recently on the use of motivation interviewing in school settings. School nurses, teachers, fascinating. There are more and more studies that are coming out that show that, you can influence kids, with their behaviors through other people, and then as I mentioned earlier, a lot of the studies with really family members influencing kids' behaviors. Yes.
I was wondering if you could speak. There was something evoke P and then another evoke. I can't remember what the P.
Illicit, provide illicit.
Oh yeah, that.
Okay.
If you could speak. I don't think this is working. Okay. If you could speak more to that, maybe an example of what that might look like.
Okay. So with the illicit, provide illicit is similar to, the ask, tell and ask, the lower level. So what you're doing with the illicit is, let's say, you want to get their perspective on what they think of their smoking. Then you really ask, you elicit that from them. And after they elicit, they tell you, well, I don't think I'm thinking about really quitting smoking now. Then you provide. You get back to them by saying, so at this point in time, that's quitting smoking is not a priority for you. Then you kind of elicit more after you really already provided. So, what makes it not a priority for you? You see, it becomes like a chain, of information that, gives you the opportunity to get to know where they are with their thinking, but you want to still come up with really that curious and itchy mind. You want to still come up with more evocative questions, because sometimes the conversation would stop, okay, well, you don't want to quit smoking now, all right, we'll talk later. This is what a lot of people have, that tendency to let go. And you know something, the people who need most of that approach are the people who are struggling with making the change. If people want to make the change, you wouldn't need to do more, to do much, basically. Because they'll move ahead, and all you need, probably a little bit of an intervention to guide them through the process, but they will go and do it. The people are mostly struggling to make the change. These are really basically the people who would need to be more engaged and more really invited to share more about their struggles, so you can come up with that approach to help them really move forward. Yes?
Hello? Yes. Okay. So I was thinking about that specifically in the context of I do sexual health
Yes.
testing, STI testing, and trying to frame some questions. But we're dealing with a lot of misinformation. So at some point, I feel the need to correct the misinformation that they may have, the misconceptions.
Yes.
But figuring out if in motivational interviewing, there's a way to say, okay, I've gotten your idea. So here's this one fact of information that, oh, by the way, XYZ.
Yes.
What do you think about that? Does that still work with that?
Of course.
Yeah.
I mean, what you're really basically doing here is you're eliciting what they know, and from what they share with you, the information is not correct, right? So you reflect back and say, look, this is how you've been informed about the situation. Would it be all right with you if I share with you what we know about that issue that you might not be aware of? And then you can share. But you need, what the most important thing that you need to do here, after they share with you, oh, really, I didn't know that, or something, is to ask them, well, how do you feel now that you know better about that situation? Yeah. How would you want to approach the issue, differently? So you want to keep that engagement. You don't want to stop at you really correcting the information, not getting to elicit from them how they feel and what they want to do with it. Does that make sense to you? Other questions, reflections?
Time for one more.
All right. Well, thanks so much for listening.